So yes, thank you, yes, and I think robotic fixed bearing restore is a 20 years follow-up, is since 2005. So yes, much older than the mobile bearing. But so I'm talking about the robotic partial knee replacement, and many of you thinking that how a hip surgeon comes as a PKR surgeon, but I make sure that I will perform both way well. And this is the three pillars of the successful partial knee. That's the positioning of the component, balancing of the knee, and the alignment of the knee, which I believe is equally important like the total knee replacement. And if you don't implant your component well, that will give the catastrophic complication like this, although that have the good track record. So key arguments by the key fixed bearing surgeons against the mobile bearing, that's poly dislocation in the imbalanced partial knee, need precise balancing, need accurate component placement, and the technically demanding. What the key arguments by mobile bearing surgeons against the fixed bearing? That's the high contact stress in the bearing surface, increase the wear rate, age loading, and the less survivorship. But as a robotic partial knee replacement, you have the better alignment and tracking, you have the precise component placement, you have no dislocation because it's a fixed bearing and the registry already proved it, Australian registry, no edge loading, and the precise balancing, 0.1 mm. Kartik is talking about 0.3 mm, while in robotic we can go up to the 0.1 mm. So, video. So this is a classical AMOA, valgus stress view opening, varus stress is closing, and the lateral view as classical Oxford criteria is okay, PFJ is normal. So we take so I will take a pause here. So in robotic, we have the CT scan based robot. So you have the LDFA MPTA preamp, and you can define the patient's pre-arrhythmic alignment, that's the AHK. And in this case, the AHK is around 4-degree varus. And so we take the standard medial parapatellar and the medial arthrotomy incision. For the robotic, you need to expose more compared to the Oxford because you need to register the points. And this is intact ACL. We mark the medial most fiber of the ACL, the medial cartilage of the patella. We insert the pins for the tracker, and this is a registration for the hip center and the checkpoints. And now we register 40 points on each side, on the femur side as well as on the tibia side. I will fast forward this because we'll discuss on the planning part. So there are 40 points on each side. And here comes so we make sure what is right now native varus of the patient. So this is a native varus of patient, 8.5 degree, flexion is the 12 degree. And we register all data, and then we'll start capturing gaps in the various poses, starting from the 0 degree, 10 degree, 20, 30, 40. Usually 4 poses required. I take 15, 30, 45, 60, 75, 90, and we take gap capture, and then comes the planning. So our goal is to balance the component placement without the soft tissue release, so that this graph which is orange, which below the horizontal line is a tight. If we go above, that's the blue is the loose. And our aim to be aim between 0 to 1. So we place our component much more on the femur side rather than, we don't play too much on the tibia side, because in tibia we have the limitations from the proudness from 2.5 to 3.5, and the varus not more than 1 degree. So first is that we take the tibia and put the 1 degree varus, and the slope is very controlled. It's not dependent upon your blade, your zigs. Once we deal with the tibia, we'll come on the femur side, and I will make all adjustment on the femur side to bring my graft in the blue, provided I will consider the osteophytes, and you can see my tracking is dead center in the femur. I will make sure that my anterior notch is not go inside the bone, and the proudness would be around 0.6 mm. The flexion, we can't go more than the 6 degree of flexion as per literature wise. We can give the external rotation. So this is the whole planning on the Mako of the partial. And this also depends upon how tight I want, how loose I want. I will consider the removal of the osteophyte and opening this gap. So once I plan, so I will check for the proudness, that's a 0.3. My tracking, that's in the center. So I will place my femoral component medial lateral to have the proper tracking to avoid the edge loading. And final tibia look, so varus 1 degree. And then I register for the lateral border of the tibia so that I don't cross the footprint of the ACL. And on the femur side, I will map the femur to avoid the overstuffing of the patellofemoral and to going in the notch. And the medial lateral, check with the medial lateral placement so that I can move my component very precisely, medial lateral. So this is and then we finish the cuts. So because of the robotic, you plan your component very well in the desired position. So we usually give that if it's 40 or 50% of the surgical time in the planning. This is a saw base as well as burr base. So proximal tibia cut and the distal posterior femur cut is the saw. And then the femur, distal femur, and the vertical tibia cut is the burr base. So once you have done planning and then you start cutting, it would take around 10 minutes to complete the cuts. So this is lug holes, also by robotics. And this is a vertical. And we make sure that we don't cross the ACL footprint and we preserve the ACL fibers. Just 2 minutes. So if you divide more than 1 mm, that the red mark will come. Okay. And this is a classical AMOA. This is posterior femur cut. And again, tibial lug holes with the robot. So I will make sure the sizing and the osteophyte before the tibial lug hole, and then we'll remove the meniscus. So in this case, we remove the meniscus after the finishing the cuts, and that gives some kind of the laxity which we'll keep in our mind while planning. And this is ACL footprint, you can see. And then trialing. So once we have trialing, we check under the robot final alignment and the gap capture to see the tightness and see whether, so we remove the osteophyte and any protruding bone from the tip to avoid the bump. So we can remove the osteophyte before cutting, And before gap capturing, and we shape the middle condyle. And this is a final element. Okay, so what I targeted as per the AHK, there's a 3.4 to 4 varas. So so in extension, it was the 3.5 varas. And I will make sure that both green on either side of the blue. So I'm tracking in the dead center, not edge loading, and that will give the good survivalship of the joint. So this is a 3.5 varas. That's the pre-arithmetic varas. And then we start capturing the contact in the various poses. And we can see the robot guide us that this is 0.1 mm loose, 0.1 mm tight, minus is a tight, plus is a loose. And if we find it's too tight, which is not usually the case, we can do some maneuver. And then the final implantation. So when I was planning to buy robot, I was not planning to buy the uni because I was doing the Oxford, but someone told me that if you want to go with the partial, you only go with the robot. And this is the final element. And you can see the green on both sides, so I'm tracking well. And this is the final gap capture after the implantation. So that comes in the green. So plan was 0.6 loose, and that come up to the 0.1 loose.
We are lagging behind.
Thank you. This is post-op.